Thank you all. Thank you for those who are following us on Zoom as well. We have a number of questions, which actually makes us very happy. But what I'm going to do is read the questions aloud and without addressing them to anyone specific among the speakers. And I'll just ask the speakers that because we are running late on the schedule, if you could reply, give a very concise reply. And then we'll be working on the website. I'll be working on the website to maybe address these questions as well. Maybe include something about these and other possible questions that people may have. So let me read two which are closely related, somewhat related. So first question here, how are the estimates of Chagas infections worldwide determined? And there's a related question to this, maybe different people will answer. The low incidence of Chagas in Brazil compared to Argentina, Bolivia, and other countries, is it mostly due to low notification or lower incidence of cases? So it has to do also with the estimates. Please go ahead.
Maybe I can answer the first part and you can answer about Brazil. Yeah. Just to say quickly, most of the global estimates that we showed were developed by the World Health Organization, and without being directly involved, I know that they use a process where they look at a variety of sources, including data from blood donations, data reported by ministries of health, and also prevalence studies. And based on a review of that information, that's how they calculated all of those numbers, which were last updated in 2015. So we'll see what the future holds for the next estimates.
Chagas disease prevalence is lower in Brazil than, for example, in Bolivia, because the triatom infestans was raised case from Brazil and not from Bolivia, for example. And in Argentina is still there, triatom infestans in some places, and there are model charge transmission in Argentina much more than in Brazil. So that's the difference in the prevalence. And also you have a big population in cities now, okay? And for estimatives, it's the same way as Colin said, they take lots of use blood donation, use studies done in small places where there is researchers that look for the entire research in a small population, then use that data. We can also see patients who have been with heart failure, and then they are going to the hospital. There are a system that get why they're in the hospital, and then you get that information that is for the Chagas disease. Okay.
Okay. Let's go on with the other question. I'm reading here. I work with fetal maternal transmission in Chiapas and Oaxaca, Mexico, where prevalence is high. I would like to know your experience regarding the following. Is the species of trypanosome in the US different from T. cruzi? So it's not very clear. Maybe it's two different questions, but it's the same. It comes from the same source. Anyone would like to comment on that?
I think they're asking if the strain is the same in Mexico versus the US, and it is.
Okay. Is there any difference in an indigenous immune system with the indigenous people's immune system who live in areas near the kissing bug in Brazil? Are there any different ways of developing the disease or anything like that? Any adaptations? This is a question coming from Brazil.
Is it working?
Yeah.
Okay. So I'm not the expert, but there was a paper that came about a month ago, I think in Science Advance or something like that. And they did a very interesting study with native population of Indians in Amazon area, where you have the tetratomine bug and the disease. And they were looking at genetic factors from the population that would stand out. So they did computational modeling, and they found out there is a gene that was present specifically on this population that is constantly exposed to Chagas disease. And they cloned that gene in a cardiac cell in the lab, and they saw that the cells were more resistant for parasite infection. So when they tried to infect that cell that had that same gene from the population, there was a lower parasite burden in the cell. So the hypothesis that these could have been a selected genetic feature from this population and make them a little bit more resistant to the parasite. But you know, it's very recent work. Might be the case. Yeah.
Before we move on, we have very few other questions. Sorry.
You have to see that there are lots of different nations and lot of different indigenous nations in the Amazon. So if the work was done with specific people, but maybe it's not the same with another indigenous nation, another place. There's lots of different nations. And the Chagas disease, there's a acute case of Chagas disease in Pará, and most of people there are descendants from indigenous. So maybe it works for one population, but not works for all the population.
And that leads to the bigger question as to why do their immune responses behave differently? Someone gets infected, doesn't get Chagas, another person gets infected and acquires Chagas. So there's something in the genetic makeup and that determines, and we don't know what that is. And that's another area that needs to be investigated, because if we can target who is going to get Chagas and get the complications of Chagas, then you can target treatment to just that group.
And I work with families, and in the same family there are brothers who have heart failures, and brothers, if you stay well, no, is also don't know why, because they were infected in the same house, the same.
Maybe, yeah, just on that, I think, as we're speaking about Chagas and neglected diseases that are so ancient and, you know, old, and they shouldn't exist anymore, but now there are so many, and we saw, you know, with Jair's presentation, how computational science and artificial intelligence, everything is contributing to drug discovery, but also I think we have to see how to make all of this new technology and digital tools work to address issues like, for example, biomarkers on Chagas, like why, you know, in the same family, I develop a certain condition and my sister doesn't, like if she, you know, if she's infected in the same. So like really, I think now gathering data as much as we can, you know, like to try to create maybe algorithms that will help determine and ask those and answer those questions. Like you have the same population, what makes someone more vulnerable to develop like complications, who just gets the infection and doesn't develop. So I think it's really a call to action for people working on artificial intelligence, et cetera, because also we were having this conversation yesterday with Daisy Hernandez. You know, all of these tools are amazing, but they have to be tools that are put towards health equity and accessibility. Otherwise, they would just amplify and exacerbate health inequities. And I think we have to, as researchers, as advocates, as clinical people, we have to strive that these tools are working towards equity and to address gaps that have existed for so long and should not exist anymore.
I wanted to quickly add something here, really quickly. During COVID, you know that Brazil, after initial complications, we had a high vaccination rate, higher than the US and then Germany and then many developed countries, for example. And you have to know that vaccinating, providing health services in Brazil is a logistical nightmare, because the Amazon is more than 60% the territory of Brazil, and there are 25 million people living there. So just to tell you that Brazil has been experimenting during COVID and now more with telemedicine. And now listening to you, I realized that telemedicine will be a tremendous way, not only of extending support to local people who don't have to be MDs or even nurses, but they just have the training to operate, to give basic care and be in touch with a doctor in a distant place. But it could also become a way of collecting data as well. Just to bear this in mind, this was my quick comment. Next question, how do trypanosomes affect health and lead to cardiomyopathy? I wonder if this question was not answered already, or do you? Sorry?
Well, very briefly, they invade the cells and kill the cells. So you get atrophy of the cells and fibrosis, scar formation that causes the dilatation and the foci for the ventricular arrhythmias.
Okay. There is a question from the audience, which is always good.
Thank you. Thank you for the talks. My name is Carolina Monchola. I'm working on Caliber right now on the kinetoplastic drug discovery. And I have a question regarding the failure of the last posaconazole, for example, and another drugs. What went wrong, basically? What can we do differently now based on the experience? Thanks.
I can start addressing this. So I think the question, what went wrong? There are several hypotheses to explain why these compounds like posaconazole, the C51 inhibitors, didn't show a prolonged antiparasitic effect. One of the hypotheses is that the parasites have a stock of ergosterol, and if they're not replicating, a compound that inhibits biosynthesis of ergosterol will not kill the parasite. So right after treatment, all the parasites that were replicating were cleared, and that's why you got that negative PCR right after treatment. But there are parasites that might be either in tissues that were not accessed by the drug, or there's also a hypothesis of a parasite dormancy, something similar than what you get in malaria with hypnozoites or with TB. So these parasites, if they're sleeping, here, they're not replicating, and therefore compounds like posaconazole would not kill them. After you remove the drug pressure, they would repopulate, and the patient would still be infected. So these are some hypotheses. Some people think you should treat for longer time, and maybe if you do these as a treatment for years, you will be always preventing the parasite from recrudescence. So these are hypotheses. The factual information that we have from that trial is that right now, anything that targets that same C51 enzyme will be deprioritized because there was already a failure associated. I think another big learning lesson from the trial was that PCR is a good marker for failure of a trial, because if you test positive, you know the parasite's still there. But a negative PCR is not a good marker for treatment success, meaning if you get a negative PCR, that doesn't mean you don't have the parasite anymore. You have to keep testing. So I think that was a big lesson learned from the trial.
Thank you. Is posaconazole and or fexinidazole, are they not improvable? Like medicinal chemistry cannot improve them further?
Yeah, I can take that one too. So they can be. The fact that posaconazole was already approved drug for other diseases, meaning they are known to be safe, it was an easy way to test them as it is the molecule against Chagas. So the idea was to repurpose it. now that we know there are issues with the target itself, if you do chemical optimization to try to make it better, you would still be targeting the same C51. And that's not ideal. And the same thing for fexinidazole. So you can think about fexinidazole as an improved posaconazole or nifurtimox, because most likely the mechanism of action of fexinidazole is very similar to benzimidazole or nifurtimox, but it seems to be a little bit safer. So that on its own would be a way to say that you optimize or made a better molecule, even though it's targeting the same thing. But I think the holy grail is to get new targets and different chemical molecules, in a sense that you could perhaps combine these different therapies to make it, safer and have less adverse effect, while also keeping good efficacy, especially on preventing the cardiomyopathy or the digestive manifestations of the disease. I think that's the holy grail.
We are very short of time. I'll do the following. I'm going to read three important questions at the same time. I will ask the speakers to comment on them very quickly. And we decided that those questions are really important and meaningful, and we'll have them posted on the website with more detailed answers for you to, and maybe we can create something for people to post questions on the website as well. Okay, well, first I'm going to read them all. Why are vaccines not available for Chagas disease? Okay, that's a good one. This one reads like Colin here. What about the platform for immunization against Chagas? Also, I want to know about IVM, integrated vector management strategies for Chagas, as we know that the vector spread can be tackled best by IVM. Third and final, and then we stop here, and please again, let's make very short answers. We don't have much time. We know Chagas has no cure. Here in Brazil, this came from Brazil, most health efforts focus on prevention. How the US, and a comment, a not very developed public health system, and I'm reading here, it's not me, devise strategies to prevent spread of the disease. Okay, go ahead, guys, up to you.
I'll take the last one really quickly. Integrated pest management is something that public health surveillance and environmental health specialists work on. First, we have to get the pest control and vector control agencies to acknowledge triatomines and how to deal with them. And we're not there yet, but we're working on it. So engaging with the vector control with the counties and with the states is incredibly important. And just being able to identify what a triatomine is important. And there's quite a few places in rural parts of the United States, like for example, AgriLife and extension agencies in places like Texas are working on that very thing. So yeah, we have a long ways to go with integrated pest management in the United States. But first is just acknowledging that we have a problem.
In regards to vaccines, they've been trying to develop vaccines unsuccessfully, and I think it has to do with the multiple strains plus the multiple DTUs that are involved. There's over 6,000 DTUs, so they haven't been able to formulate a vaccine for Chagas disease.
About the same subject, I think also the big problem is that it is a neglected disease. So there is no much effort, no much investment in really developing the vaccine. Because there are a lot of studies in animal models showing that a vaccine is possible. Of course, there is the point that was just rise of the diversity of the parasite, but this can be is not. I think the most important reason is the lack of funding.
Okay, we had that one about the Chagas platform for immunization against Chagas. want to say something?
I'm wondering if the question was addressing more like what would be a good platform for immunotherapy or for vaccine, which might be more Maria's territory.
Pardon? Yeah.
The question was, what about the platform for immunization against Chagas? That was the same person who asked about the IVM.
Yeah. I don't know what does it mean about platforms for Chagas, but I mean, there are a lot of
I'm sorry?
research in Brazil and in other countries looking for a possible vaccine, and there are several candidates, and I think it's just, as I said, a problem of investment and really of the also of the big pharmacies company said that it's neglected, as we just said.
Okay, allow me to conclude here. Carolina wants to add something.
No, maybe just so we end in a good terms, in positive and optimistic terms. I think again, this whole conversation about the lack of funding, and we saw like limited funding and how diseases get funded differently because of their priorities and who they affect. But I think also we're just still in the COVID pandemic, and we saw how much was done in terms of development of new tools, including vaccines, in record-breaking time. A lot, the result of public, private investments, collaboration, unprecedented collaborations between governments and national agencies and regulatory agencies to expedite the registration, engagement of people, so many lessons that I think we can learn, even like the issue of diversity, equity, et cetera, on representation of clinical trials. So I think we should not lose momentum, and we should not lose sight that, COVID has proven it's possible to do things very effectively, to do things in collaboration, to fight a global pandemic. So we should use those and apply those lessons for diseases like Chagas and other neglected diseases.
Okay, with this, if you allow me, I will just mention one effort I'm aware of. It's taking place at the University of Texas at El Paso. Maybe someone would add or correct something about that. There is a researcher there, a Brazilian called Igor Almeida, and apparently he's been conducting work on a possible vaccine against Chagas. So as Carolina said, we have to end on a positive note. I would like to tell you that in my own case, in very few days of my life, did I learn so many interesting things. I'm very grateful to the speakers, for all those of you who made a personal sacrifice to be here and to contribute to this event. I think it was very instructive. Mayra, your testimony was mind-opening and heart-opening as well, in a good sense. And so thank you all for taking part in this in the audience and on Zoom. And thank you. If you want to say some final words? Or?
We just appreciate you all being here. This was an effort of a team, and I think you said it well, the sacrifice of our speakers to be here. And thank you all for spending your day with us and sticking it out on Zoom too. If you're still there, we're grateful that you were here. I do have some parting gifts, if we call it that, for our speakers as a thank you in the back. And then I would also thank the conference organizers, all of our support staff. And I do know that they have said we have a hard stop to be out of here by 2 o'clock. So just FYI, take some food on your way out. And SDSU, School of Public Health, our Brazilian Studies team, we all thank you for being here.
Thank you all.